How are you? Welcome, everyone. This is IHA's webinar, and we're pleased to have you here. We'll get started in a couple minutes. I'm Julie McKinney. I'm going to moderate the session with our experts here, and we're just waiting for some people to get on, and then we'll start in a couple minutes. We'll do some housekeeping and then let you hear from our speakers. Okay, just gonna wait, people are coming on. Again, welcome everyone. This is IHA's webinar, Choosing Communication Strategies for Building Health Literacy Capacity. We'll get started in just a minute. Glad to have everyone coming on. All right, I think we'll get started. It's 1 minute past the hour, and I'd like to give our experts some, as much time as they have. So again, let me welcome everybody to our webinar, and just going to go through some quick housekeeping, and then we will get started, and I will introduce our speakers. So if we could move the slide. Yeah, to here, thank you. So just want to let you know this already. You'll all be muted during the webinar. If you want ask a question for our speakers, please use the Q&A button at the bottom right at the bottom of your screen. And you're welcome to share, introduce yourself, share ideas, comment in the chat button. But we'll use we'll take the last 10 or 15 minutes to share your questions with our speakers. From the Q&A button there. If you have any technical difficulties, you can email support@healthliteracysolutions.org and they'll help you out. The webinar will be recorded and it will be posted on the Health Literacy Solutions Center on the webinar page. You will have the recording and the slides on there. So know that. I'll put all of this in the chat so you have it. For those of you who want CE credits, there will be an evaluation emailed to you after the webinar. And if you fill out the evaluation and send it back, then you will get your credits emailed to you. So with that, again, any questions, just put them in the Q&A and feel free to comment and share on the chat as well. Let me introduce our first speaker. First of all, welcome to all of our speakers. I'm just gonna call you out and you can wave who's who. Georgia Weiss Elliott.
Hi,
and
everyone.
Laura Aviles, Dr. Satya Sarma, and Lisa Blue.
Good morning.
So welcome to all of you. We're really excited to hear what you have to say. I'm just going to start off with Laura, and then Laura will introduce the next one as we go down the line. So Laura, welcome everyone. Laura Aviles is a program coordinator for the Yuma County Public Health Services District, working in public health. Before this, she was a health educator for 19 years, specializing in the health promotions division. So Laura, your experience is right up the health literacy alley, and we're excited to hear what you have to say. So with that, I will turn it over to you.
Thank you so much, Julie. So hello, everybody, and welcome to Choosing Communication Strategies for Building Health Literacy Capacity webinar today. So we're really excited. We're going to be sharing 2 projects in Arizona that are both working towards advancing health literacy. Before we begin, I'd like to share that we have most of our slides. They're translated in Spanish. We do this because we want to challenge ourselves to be inclusive and include multiple languages when we deliver presentations. Including multiple language, it's challenging and it is a work in progress for us. So you will notice that some of our slides, they do not have Spanish translation, but we are happy to provide those to you at a later date if you'd like. So I also wanted to add, we are located in the furthest southwest part of Arizona. We're bordering alongside the state of Sonora, Mexico. So the Spanish translation, it's responsive to the community we serve. So as you heard, I am joined today by my colleague, Georgia Weiss Elliott, as well as Dr. Satya Sarma and Lisa Blue, who work alongside from Maricopa County Department of Public Health. So during our presentation, we will be providing you with an overview of the health literacy grant. We will discuss health literacy and then both of our counties advancing health literacy projects and the unique approaches by each county. Then we are going to conclude our presentation with a discussion of shared challenges and successes, and we're going to open it up for questions. So both of our counties, we were awarded Advancing Health Literacy to enhance equitable community responses to COVID-19 by the Office of Minority of Health. And this was a 2-year grant whose purpose was to improve health literacy on COVID-19 information, which includes increasing access to culturally and linguistically appropriate health information, also to improve responses to public health strategies for COVID-19 and related health outcomes among racial and ethnic minority populations. So I want to share, in Arizona, 4 counties were awarded this funding. They were Gila, Pima, Maricopa, and Yuma. We were all brought together through a working collaborative convened by Pima County, and we're known as the Arizona Advancing Health Literacy Collaborative. And through this work group, we were able to share progress, successes, challenges, and we were able to work together through grant reporting requirements and build statewide deliverables. So if you take a look at the map on the slide here, it shows you where Yuma County and Maricopa County border each other. And even though we border one another, we are very different. So Yuma is mostly rural county with large agricultural industry, and it borders alongside Mexico, and there's a large binational community here. I also wanted to add, here in Yuma, there are many mountain skylines in almost every direction. The sun shines nearly every day of the year, and you're about a 2.5-hour drive to San Diego, to Maricopa, which is Phoenix, Lake Havasu, Palm Springs, and a couple of hours further is Las Vegas. Now, Maricopa, on the other hand, it's mostly urban county with a large and diverse metropolitan area, and is Arizona's most populous and fastest growing county. And it's the largest of Arizona's 15 counties and the 4th largest county in the nation. So health literacy, what does it mean? I'm going to cover some health literacy terminology before we dive in. The CDC defines health literacy in 2 different ways. Firstly, through the individual, and then through the institution. Personal health literacy, it is the degree in which individuals have the ability to find, to understand, and use information and services to inform health-related decisions and actions for themselves and others. Whereas organizational health literacy, it is the degree in which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Next, we have culturally and linguistically appropriate services standards, which are known as CLAS. The Office of Minority Health has created and defined the CLAS standards to promote health equity. So these standards that these are standards that healthcare institutions can use and follow to provide more accessible services to diverse needs and populations. They help guide organizations to provide health services that are respectful of and responsive to the health beliefs, the practices, and needs of diverse patients. So this is the background and reasoning for the Advancing Health Project strategies. So now I'm going to pass it to Georgia, who will be discussing Yuma County's Health Literacy Project.
Good morning, everyone, or good afternoon, depending on where you are. My name is Georgia Weiss Elliott. I'm a participatory evaluation specialist at the Participatory Evaluation Institute in the Arizona Prevention Research Center at the University of Arizona. As you heard, I work closely with Yuma County Health District in several areas, including community health workers and health literacy and COVID-19 mitigation. And today I'm excited to be sharing information with you about the Yuma County Health Literacy and Equity Project. So brief background to complement what Laura has already said. Yuma County is a multicultural border community located in the southwest corner of Arizona. It is neighbored by the state of California to the west, and then Baja California and Sonora states of Mexico to the south. It has a high traveling and dynamic population with continuous cross-border movement. The total population is 229,957. However, the most recent estimate suggests that an additional 150,000 people, including seasonal winter visitors, agricultural workers, and regular border crossers, live, work in, and frequent Yuma County. So the total population is actually much higher. 69% of the residents are of Hispanic, Latino race or ethnicity. And although in areas of the county, that percentage is a lot higher. Agriculture is the leading industry in Yuma County. It's the lettuce capital of the world, and there are approximately 38,000 migrant and seasonal workers. More than 91% of the leafy greens sold in the US in winter are produced in Yuma County. According to the Social Vulnerability Index, 12.3% of the population is uninsured medically. 18.5% speak English less than very well. And there are high social vulnerabilities across 4 themes, including household composition, housing and transportation, race, ethnicity, language, and socioeconomic status. To discuss the strategies of the project, the target populations are farm workers, Hispanic, Latinos, both youth and elderly, and communities most vulnerable to the effects of COVID-19 in general. There's both a community and institutional focus of the project. Today, I'm focusing mostly on the institutional aspect, how to institutionalize health literacy best practices, but I will also be touching on some of the community or individual strategies of the project and the activities that have been implemented so far. Before I dive into those strategies, let me introduce more of the partners. So Campesinos Sin Fronteras, which is in the middle column, is a community-based organization run by community health workers that connects farm workers and migrants to health, legal, domestic violence, youth services, and much more. They also run a radio station called Radio Sin Fronteras. And Campesinos Sin Fronteras is an integral part of the project's community outreach and campaign efforts, including senior support groups, radio PSAs, and social media campaigns. And then, as I mentioned, I work at the Arizona Prevention Research Center. I'm part of the evaluation team for the Health Literacy and Equity Project, and we help with creation and implementation of evaluation tools and data collection and reporting. So diving into the activities, the first activity under the institutional strategy is the organizational class assessment. Again, CLASS stands for Culturally and Linguistically Appropriate Services. We compiled, created, and piloted the assessment and have completed it with the health district as well as with 2 community-based organizations. The assessment is designed to evaluate current practices and knowledge related to the CLASS standards. It recommends areas for improvement in meeting the CLASS standards and suggests strategies for sustainability and capacity building, as well as for CLASS trainings and resources. So in other words, what are the avenues, or what might the avenues be for an organization looking to institutionalize health literacy best practices? Where can infrastructure be built within the organizations? And particularly, what assets does the organization already have for doing so, and how can they communicate that to others outside the organization, including funders? And so the assessment itself has 3 to 4 parts. There's an employee survey, a leadership discussion, and then a next steps. And all of that is a next steps discussion, and all of that is combined into a final report. In addition to the assessment, a health literacy toolkit was also created and implemented into workflows. Community health workers at the health district researched and designed this toolkit, which uses PMAT and CDC Clear communication guides to aid in reviewing and evaluating printed and digital campaign materials distributed to the communities. Staff have received training on the toolkit, and it is being integrated across programs to evaluate public-facing media and materials. It also helps ensure that all media is increasingly presented, like this presentation, in dual languages for the community and beyond to better access the information. And so on the right-hand side, you can see a screenshot from the guide that was created for using the toolkit. And this is one way of automating and institutionalizing health literacy best practices by implementing this review of materials into workflows. Moving towards the community strategy of the health literacy project, but still describing best practices that can be institutionalized. The Ask Me 3 tool has been an integral part of the health literacy project. Ask Me 3 is like it sounds. It's 3 questions that patients can ask their provider to better understand and manage their health status. This tool has been translated by community health workers at the health district and modified for the local context. And so as we've sort of touched on previously in this webinar, often tools that have a Spanish translation are not tailored to the regional dialect, and they may not even be close. And so therefore, even though they're in Spanish, they're still not accessible to community members. And that was the case with this tool. But since its translation, staff across the district have been trained on the Ask Me 3 tool, and it's being used within other programs as well. I've mentioned community health workers a few times now. And so here I hope to continue to highlight the community outreach and education that is happening, but also some of the people who are instrumental to creating effective and understandable health campaigns. CHWs, as many of you know, are members of the community that they serve. So they're very close to the target populations that this grant is looking at. As our partners demonstrate, teams of CHWs work to review materials for relevance and understanding and provide necessary context for distributing information. They can also provide tailored and culturally relevant educational opportunities for vulnerable populations like those that have been happening in Yuma County through the Ventanillas de Salud senior support groups. These groups take place regularly across the county, and participants have been educated on how to use their cell phones, not only to text and call and take photos, but also to access health information online. Health topics have also been covered, how to find credible health information and other topics that the participants say they are interested in. And so because CHWs are so very close to the communities, they can monitor topics of interest or opinions, as well as fear or misinformation that are going around the community, and respond quickly and effectively through social media or through any media campaigns and educational opportunities. Some successes that I have not yet mentioned about the Health Literacy Project: in-person and social media activities have reached over 45,000 individuals. Media campaigns through local and regional outlets they reach an estimated 300,000 individuals every quarter, and part of that is because we send campaigns through large regional and national outlets such as Telemundo. Radio Sin Fronteras is run by our partners Campesinos Sin Fronteras, and then other local and regional outlets as well. And the Health Literacy Toolkit has helped review program materials outside of this project, including child safety and injury prevention materials, COVID-19 education, and diabetes management program materials as well. Some challenges we've had includes translating health literacy and health literacy terminology. And so even in English, we've had a challenge thinking about what does health literacy mean to community members, even in English. How do we translate that to Spanish? And what is the true meaning behind the term health literacy? And what are we hoping for community members to understand about that and these terms and related ideas? Finding local and relevant class trainings continues to be a challenge for us. And then some of our tools, adapting some of our tools for community-based organizations versus health departments. So our assessment, for example, and making sure that despite the differences in structures and organizations, that those tools can still be used in the different types of organizations. And then a challenge for everyone continues to be community engagement and combating misinformation around COVID-19 topics, as well as vaccine hesitancy and the continued challenges of communicating about COVID-19 in today's world. So some tips and tricks that we've found effective include finding and adapting existing sources, continuously, rather than reinventing the wheel, continuously reviewing and reassessing information, including the best way to present that information, which changes frequently, especially with COVID-19, finding ways to integrate health literacy practices into existing programs. So we've found a few ways to integrate health literacy practices into workflows, and that sort of automates this process. Building long-term relationships with community members and or community partners, which also goes hand in hand with incorporating and building capacity for CHWs within programs and organizations. So community organizations and community health workers are both very close to the communities, and those have been integral to this health literacy project. And so these are the approaches that we took in Yuma, and now I'll pass it over to Dr. Satya Sarma to tell us more about Maricopa's approaches and strategies. Thank you.
Thank you. Thank you, Georgia and Laura, for that lovely overview. And thank you all for allowing us to share some of the Arizona experience with this very national audience. It's really lovely to see you all here. My name is Satya Sarma. I'm a physician and internist. I've been here for nearly 40 years, more years than I care to remember. But in addition to practicing, I have a background in population health. I've served as chief medical officer for some of the Medicaid plans here, worked at Medicaid before really entering more of a public health role as principal investigator for this project. I will be co-presenting with Lisa Blue, my partner in crime and co-PI on this project. I'll be giving you a little bit of an overview of Maricopa County, our approach, and we took a very different approach. We are a very different looking county, as Laura pointed out. And then I'll be handing it over to Lisa to go over some of the details of our strategy. And then I'll be coming back to give you a little bit of our, outcomes, successes, challenges, etc. But before I even get started, I do want to acknowledge our amazing team at Maricopa County, which we aren't able to do this without the amazing guidance and oversight of Lily Cardenas at County, and our team has been, the work has really been shouldered by amazing people like Julian Avila and Shea Correa, who I think is on the call. So thank you for being here. So just a huge heart shout out. So Maricopa County, as as Laura pointed out, is a very different county than Yuma. We are the fourth most populous county in the U.S. with a population of well over 4 million. More than half of Arizona's population lives in Maricopa County, and it includes 24 cities, towns, and unincorporated communities, including, of course, the fifth largest metropolitan area in the country, Phoenix. And it's also the fastest growing in the county in the U.S. We also have 5% of our county land is tribal. So that's another difference. About 44% of the population are ethnic minorities, and nearly 5% has limited English proficiency. So moving to the next slide, this project was really focused on populations with the highest risk for health disparities, including racial and minority and ethnic minorities, uninsured populations, populations with limited English proficiency, households with more persons than rooms, and populations with the highest COVID-19 positivity rates as they were being identified by our state data, our state level data. That means that Maricopa County has a moderate to high level of social vulnerability on the SVI index. And that comes in at 0.6354. The median household income is about $71,000. $500 per year for most families. And in addition to a large Hispanic or Latinx population, we have an immigrant community with roots in many different languages and cultures across the world, and a large population of refugees and migrant workers in Phoenix, as well as across Maricopa County. So as I mentioned, we took being a much more urban county, we took a different approach, and really we took a little bit of that strategy of really figuring out how we could create a program that could actually embed the community health workers into existing healthcare institutions. And what that meant for us, the way we approached that, is to have community health workers partner with FQHCs to outreach to patients for COVID-19 vaccination testing, and also to help improve their health literacy on information that would mitigate the spread of COVID-19. We did, in fact, narrow in on the high SVI areas within Maricopa County, the highest SVI areas within Maricopa County. And we partnered with community health clinics, FQHCs, in those particular communities. And we also took an approach that would be broader because of this, this sort of urban, very diverse population. We wanted to be able to serve not only the Hispanic, but the Asian American, Native Hawaiian, and Pacific Islander communities, as well as the refugee, immigrant, and migrant communities. And what we did was basically decide to deploy a workflow that would allow those community health workers in existing community-based organizations partner effectively with community health clinics to improve the health literacy of these underserved populations, these target populations. As you can see, moving on to our partners, this involved bringing together a really large number of partners, and it was a complex project as a consequence. We ended up recruiting 3 FQHCs to this project, and while I didn't have room to put the names of people on the slide just because of the number of partners, I'm going to read them out to you. At ValleyWise Health, one of our largest FQHCs, Omar Hankton and Teresa Enriquez are leading that project. At the Wesley Community Health Center, Lynn Moriarty and Gina Lucero are really helping partner with us in this particular endeavor. At Valle del Sol, another FQHC, Shelley Ross, Imran Kirkland, Vanessa Guzman are all involved. And then we also brought together some existing community-based organizations that really, have the community health workers in them. One of the first to work with us was Helping Families in Need, headed by Edney Gonzalez and Leslie Mendoza. The International Rescue Committee, which is the refugee resettlement agency in our area, with Lisbeth Gonzalez and Kate Chisholm, really helping us in this particular project from that organization. At Unlimited Potential, which is a community health worker organization as well, Emma Vieira and Gabby Hernandez. And at APCA, the Asian Pacific Community in Action, Zina Tazan and Lyle Rabat are leading this project. And then we had an academic partner in the amazing ASU Southwest Interdisciplinary Research Center at Arizona State University. And they are really our evaluation partner in this project, helping us understand what our outcomes are and what lessons we can learn and help disseminate to all of you from it. And I just want to call out the amazing partnership of Dr. Wendy Wolferstieg and Dr. Maria Aguilar Amaya. Well, really a cornerstone of this workflow, bringing these organizations together to be able to effectively outreach to people in the community that we wanted to reach, is our technology partner, Provider Tech, and Lisa Blue, who's the VP of Clinical Innovation, and Sarah Erickson, where are our partners leading, our efforts here. But the technology platform is really what stitched together, as you'll see, the FQHCs and the community health workers to be able to have a seamless workflow. And you'll hear from Lisa in just a few minutes. Okay, next slide. And I'm just going to give you a very quick overview of our approach, and Lisa will delve into the details. But we knew that the community health centers were already testing and serving people in the communities, testing exactly the populations we wanted to reach, vulnerable individuals. They were already providing testing, case management resources, and of course, when vaccinations came out, COVID-19 vaccines. Meanwhile, we had community-based organizations also already engaging these communities. And so we wanted to create a link so that the community health centers could outreach to patients who needed management of their chronic disease, preventive screenings they were missing because of COVID, but also, of course, COVID-19 vaccines and connections to local resources. And we opted to use a technology platform that allowed us to do that outreach via SMS technology, that is text messaging, short messaging services, or text messaging. That platform also allowed those community health centers to partner with those community health worker organizations within those communities to ensure that once patients were engaged, they could understand and access the information they needed to improve their health. But also that allowed the community health workers to build a bridge of trust between the healthcare providers, the community health centers, and their patients, build or actually strengthen any existing trust they had. The other thing the community health workers did was really ensure that they were able to really fulfill that personal health literacy by being able to access resources to address their barriers to care. And that's what you see displayed on the slide. So as an example, if a patient tested positive and for COVID-19 at the community health center and had needed to pick up dinner on the way home, the community health center could connect them to the community health worker who, instead of having a COVID-19 positive patient enter the grocery store, could pick up a food box for them and deliver it to their home, along with masks and sanitizer and instructions on how to help ensure they mitigated the spread within their own households. So with that, I'm going to pass it on to Lisa, who's going to give you a little bit more detail about the strategy, and I'll see you in a few minutes.
Thanks, Dr. Sarma. So as Dr. Sarma noted, we took a bit of a different strategic approach given our communities and the needs within those communities in Maricopa County. So we collaborated directly with our community health center organizations to prioritize those key populations for outreach. As you probably all know, community health centers are already serving those most vulnerable populations, and we use this model to really extend that reach beyond the FQHCs and really drive that care. So some of the examples that we prioritized for outreach was chronic disease gaps in care, such as diabetics or patients with hypertension, as well as cancer screenings. We did this to really start that conversation in a maybe easier way or a lower threshold for barriers for patients that did have concerns about COVID-19 vaccines. So we worked in that partnership to identify what were the quality goals within an organization and how could we begin the conversation around those gaps in care. As Dr. Sarma already noted, we scaled that outreach by using secure text message. The provider tech platform allowed patients to interact directly with their care teams. And so using that two-way text or bidirectional text conversation, that really improved the patient experience in being able to access their care team and really just to improve the ease of communication, that right communication with the right person at the right time. It's also how we coordinated all of those various partners that Dr. Sarma already mentioned, right? It's really exciting when you have that breadth of partnership, but sometimes that coordination gets tricky. So we used this platform, so we were all seeing that communication across these various health centers. QI, we did develop a primary model or workflow that I'm going to go into on the next slide, but we worked very closely with the FQHCs to align with their existing workflows. We all know if a new workflow or a new model doesn't align with existing workflows, then often people create workarounds. And so that was really part of our approach as well, to understand what FQHCs were already doing and what adaptation did we need to do as a project team to best support them and their patient populations. The CHCs and, just one second, Georgia. The CHCs and community health workers both use the two-way text. They use that to share the patient education to increase health literacy. The CHCs really served as that initial contact point where the CHCs addressed, or excuse me, the CHWs address a lot of those potential barriers to care that are exacerbated by social determinants of health. Our SMS platform also supported multiple languages. We began this project in scope to only support English and Spanish, but as the project evolved, we continued to evolve the technology to be able to support those other populations that Dr. Sarma referenced that are really prevalent here in Maricopa County. Next slide. So as I mentioned, our strategy was to use text message to scale that outreach, increase health literacy, and to really overcome some of those barriers that were created around the misinformation of COVID-19 vaccinations. So here's an example of leading with that gap in care. So we provided a little bit of education, in this case to a diabetic population, about how they could access that care, and created the opportunity using two-way text to make it really easy for them to access that appointment. All of the tools, once the patient engaged with this gap in care, then the community health center organization continued the conversation to begin to start introducing or talking more about the opportunity to get the vaccine if patients hadn't yet had their initial vaccine or hadn't completed their series. We have since evolved to include patients that are due for boosters as the program has continued to expand. All of the tools and the text scripting were also evaluated by our evaluation partner, CERC, evaluated against those class standards. Next slide. So this is that primary model that I referenced. And you can see all the way to the left that there's really 4 key stakeholders here: the FQHC organization or CHC organization, the grant work group. While they're just referenced in that initial work, they were really working behind the scenes throughout this to support these partners. The CHW or refugee resettlement organizations, and then the technology partner Provider Tech. And so because we kicked this project off when vaccines were really still being accessed at different events as opposed to within a clinic or within an individual appointment, we looked for those vaccine events within the communities, especially that were close by and accessible to the various FQHCs. The first FQHC we started working with actually had a weekly internal vaccine clinic, and so we obviously promoted that. The FQHCs then queried from their EHRs patients that were unvaccinated that also had those various gaps in care. The Provider Tech sent out those text messages to the patients that were identified, and then once the patients responded to those initial text message regarding the gap in care, then that conversation could progress to not only scheduling that gap in care appointment, but also progressing to getting the vaccine event or appointment scheduled. And sometimes in some instances, patients were willing to proceed, in which case they were registered for the vaccine event. When they still had hesitancy, we let them know that they could reach back out to the FQHC at any time with questions. We also provided them some education that maybe would help reduce some of that misinformation that they had received regarding COVID-19 vaccines. We also used our technology platform to continue that communication to our CHW organization. So once a patient was scheduled, the CHWs then picked up that communication to help remind that patient about the upcoming appointment, ensure that they didn't have any barriers to getting to that appointment, such as transportation. They also did a post-visit checkup with those patients to ensure that they were able to attend, they received the vaccine, did they have any questions, and if so, they were reconnected to their FQHC partners. What's not referenced in this workflow is we also do have a survey that is sent after patients engage to that initial response, and it really is evaluating some of those health literacy principles. Did they feel that the person that they spoke with understood their needs, communicated appropriately, et cetera? So high level, this is our workflow. As I said, we adapted it through that implementation with the various FQHCs. But I'm going to turn it back to Dr. Sarma now to talk about some program successes.
Thank you, Lisa. As Lisa was pointing out, a big part of our project was really establishing a model that would allow seamless, collaboration between the community health clinics and the CHWs. One of our successes is certainly that we are demonstrating the viability of that model. We've been able to have, the FQHCs and the CHW organizations really enjoy working with each other in our project. I think they add a lot to each other, in terms of being able to understand and really be more effective in their service to members of the community. We're able to show that we were able to use technology and workflow design to facilitate more effective and efficient collaboration. One big success of our program is that when we started this program, we could only send texts out in English or Spanish, basically in the text in the regular in the Roman alphabet. One of the big successes is that more recently we've been able to solve for that gap, and now we are able to send out text messages in up to 49 different languages with different scripts than the typical Roman alphabet. Actually, I hope that's what it's called. I can't remember that one, what the name of our alphabet is, but anyway, moving on to the next slide. So, we had 4 pre-established outcomes. We did want to develop health literacy tools that included use of text message data. And we did want to create this network of community health workers as a safety net. We were interested in improving the patient's perception of CHWs, of community health workers. And we wanted to increase adherence, of course, to COVID-19 prevention, treatment, and immunization. At the same time, the 4th major sort of area of outcome that we were looking at was identifying and reducing the barriers that impact COVID-19 through social determinants of health. We did, in fact, find that we were reaching the population we were targeting. So 81% of our target population identified as belonging to a minority race or ethnicity. Nearly 2/3 identified as Hispanic or Latina. 2/3 identified as female. 38% of the patients we outreached have limited English proficiency, and Spanish was the second most prevalent language at 31.6%. But then we also found there are a lot of other languages and cultures that may not have risen to that statistical level, but that need our efforts directed at them to improve their disparities, and we were able to figure out a solution for that. And you saw that the median household income was $70,000 in our target population. Nearly half of the population indicated a household income below $20,000. So we do believe we reached the population we were targeting. Moving to the next slide. So to date, we've been able to outreach nearly 42,000 people. Our engagement, that is the back and forth with patients, is about 2,779. So that's almost, it's about 5.5%. We have shown a lot of success with respect to being able to get people to want to come in to close the care gaps that they've developed during COVID-19. So for instance, coming in for their well woman exam, for diabetic testing, for cervical cancer screening or colorectal cancer screening, and to, receive the information around that. As Lisa pointed out, that was one of our approaches initially to engage folks. Okay, thank you. Moving on to the next slide. So let's talk a little bit about our challenges. I'll highlight a few here. Maybe the most important one is vaccine hesitancy is real. I'd bold that on this slide if I could. We found a lot more engagement on care gaps than we did on vaccine uptake in our population in Arizona. This was a complex project with startup and administrative delays. We definitely learned along the way about how to enhance our workflow, and as I say, build the capacity for that larger language range. The most incredible thing about this, and I think the argument for really anchoring healthcare in communities, is what we're finding is that our healthcare providers are learning a lot in the interaction with the community health workers to better understand not only their own capacities and limitations, but also about the populations, the communities they serve. We have definitely, to highlight what Georgia said, we approach this from the standpoint of creating the workflows and the collaboration. We definitely see the need for capacity and resource and tools, training and tools to be built for the CHWs, including, for instance, training CHWs to understand chronic disease and preventive care. We do have ongoing plans to try to extend this project, and we're continuing to work with our partners to refine the workflows, as well as scale outreach to additional populations. Our Medicaid program is called Access, AHCCS. They've actually started paying for community health workers as of April, and we are seeking, avenues for sustainability through that payment structure. And I'll just very quickly highlight a couple of our lessons learned. The need to really support certification and training so that people can be absorbed into the payment model. We definitely see the importance of a pan-government and a pan-social approach to this problem in order to be able to sustain it. And then, it's not just about building core capacity. Beyond core capacity, we need to develop a more nuanced understanding of our community. So for example, we've now been able to send text messages out in Arabic. Arabic in Syria is spoken very differently from Arabic in another part of North Africa or Asia. And with that, I'm going to hand this back over to Laura to help tie in some conclusions that we made together in partnership here.
Thank you, Dr. Sarma. So in conclusion, we had two different approaches that were responsive to the unique needs, capacity, and environment of our two counties. Some of our overlapping challenges, we both struggled to address misinformation and vaccine hesitancy and finding the right language to reach across populations. Some of our overlapping successes is we successfully partnered with community health workers. We were successful in reaching community members and working towards decreasing disparities in access to care and information. We also found that there were overlapping needs, such as tools, training, and resources for community health workers, and how to incorporate health literacy into the workflow of the organizations, and adapting general resources to specific needs. For example, the class assessment, health department versus community-based organizations, and workflows customized to different clinics. So once again, we had two different approaches, but we found that strong partnerships with community health workers and our community-oriented organizations has allowed our work to reach larger participants and engage with them more meaningfully. So that completes our presentation. We thank you all for attending our webinar, and now we will open it up for questions. Thank you.
Right. Thank you guys so much. That was really great to hear about. It sounds like, you've thought out this approach like really carefully and made sure it's inclusive and tailored to your, very diverse state. So it was really nice to hear about how you did that. And, so in that spirit, there's a few questions from participants that I'm just going to pass on. So one of them, so with Arizona being a huge senior state, how do you achieve cooperation in the population of older adults, especially in Maricopa County? That's the first one.
And I can field that one. It's a great question. We really saw the value of having community health workers, people who are already in the community involved with really all of our vulnerable populations, including seniors. I really think that played a huge role in being able to address some of the hesitation that people had in engaging, particularly early on in the pandemic. But even now, as it's been more about care gaps. I'll give you an example. We had an older, very early on in this project, before it was actually a grant-funded project. We had an individual who was living in a trailer. She was retired, and she became COVID positive. Her son wasn't. She was living in a trailer. And because of this program, she got a call from a community health worker where she shared this information and her concern about how she was going to prevent spreading, or infecting her son. As it turns out, because of this program and because of our structure, the community health worker was able to uncover that need and also address it by letting this individual know that Maricopa County offered hotel rooms for exactly this. But it was the kind of, it's really around being able to wrap your arms around that individual and their specific needs. And it's even more powerful when it's by somebody who lives in that community and understands exactly what those challenges are like in a very personal way. Lisa or, Georgia or Laura, if you have anything to add.
Well, we also have some more questions now. So if it's okay, we'll move on through them. And, just to let everyone know, if your question doesn't get answered, what we're going to try to do is have the panelists write something up and we'll send it out. So we'll try to get through these. We have a bunch more now. So we'll see what we can do in the time we have. So you were talking about there was a 12% uninsured population in Arizona. So Justina wants to know, so does this population include the migrant workers? Does it have access to information on health literacy and interventions and treatment services? And is the Affordable Care Act open to that 12%? I mean, it should be, but just sort of how does that work with the numbers?
I can speak to that for part of that question. I don't think I can answer all of those points, but some of the migrant workers are H-2A visa workers. A large part of the ones in Yuma County are. That's not the case for other counties in Southern California, or I'm not sure about Maricopa, but they are covered if they're H-2A visa workers and they do get health insurance largely through their employers. There are some undocumented workers and certainly folks who either, that 12.3% could include those folks. It could also include people that don't, people without a citizen status, so they're ineligible for Medicaid. Or it can include those who just are needing that access to that service. What was the last part of that question?
The last part was the Affordable Care Act. They have access and do they include the seasonal workers? So I think
So yes
Yeah.
and no.
Yeah. Yeah.
Yes and no. I don't know if Satya, you want to say something about Maricopa's population? And that 12.3% was for Yuma County. So it wasn't for the whole entire
Okay.
state.
All right. Okay. But it sounds like that, your efforts to make sure that interventions and services and information are put out, it includes that population. Right?
Correct.
Yeah. Okay.
Correct.
Okay, so there's a couple questions on community health workers, which is really important. So one question is, what tips do you have for organizations that are partnering with CHWs for the first time? And then another one is that community health workers often seem overwhelmed and tend to refer out to other programs with not much follow-up or advocacy for the family. So any ideas in enlisting the help of community health workers, especially if a program doesn't have money to pay for them. So sort of two things, but all about tips for working with CHWs.
So I'll kick this off, and then if any of my colleagues want to jump in. I think the most important thing is really having a very collaborative approach. And so as I referenced, we worked with our partners to really understand what their workflows were and where could CHWs help support that and extend that reach. I think that's a really important piece. The work that CHWs are doing is very important and already provides a lot of support, but we know that beyond the walls of those CHCs, there are other needs that come up. And so understanding really who's doing what in that workflow, and how to best maximize the available resources. I do think having a technology partner like we did in the Maricopa project is really important, because it enabled all of those roles to be able to see that communication, whether it was with the patient or back and forth between the CHC organization and CHW. And I think the last thing that I do want to add is really to challenge one another. Sometimes we all get used to the way that we've always done it, right? We hear that in healthcare all the time. And so sometimes making change can be hard to do. And so to really, through that collaboration, ask questions and, what's the best way for patients to be able to access that care, and just being really mindful of not creating additional barriers in an already complex healthcare system.
Can I add just a couple very short points to that? Because I think you said it beautifully, and I think it's a great question. So a couple of things about, I think there's this question about what do we do when our program does not have the money to pay for them? And I think this is where getting change across agencies. So we're very lucky that in Arizona, we've been having this conversation for a while, so that Medicaid is now, in a position to cover codes. For CHWs, is actually planning to create a provider type for CHWs and has a certification process in place to allow that billing to occur. I think it's just so important to think about that, because we often get grant funded projects that do great things like our two counties have, and then the grant money dies up and the system just doesn't sustain them. So I would definitely encourage all of you across the states you're in, this is definitely a model that can have a great impact on reducing disparities and reaching communities that need us. So I just wanted to say we need the systems to respond to make it viable.
Great. All right. Thank you so much. Let's just do one quick one. This doesn't seem like a quick one, but if we can take, just 1 minute to answer this, and then we'll just close things out. And then, like I said, we'll try to get answers for the rest of all your questions out to you through email. But so did you all have barriers around low literacy despite language, and how did you address that? It seems like you tailored the language very specifically, but what about the literacy level within the language?
Yeah, I can speak to that just a little bit, that those, clear communication guides in the PMAT definitely help. But again, it's really, we've worked a lot with CHWs, and so much of our material is referenced with them. And even within the organizations we partner with, just having that, what are people going to understand what words, and there's so many tools online that I think it can sometimes feel overwhelming. But it definitely helps to have people on the ground to do that, or to have someone who's monitoring social media or news, or on sort of in the community if it's not a community health worker. And so that's what I would say, is that we've really relied on community members as CHWs and project staff.
Okay, great. Well, thank you all so much. We have the other questions recorded, so we will try to get answers to people. Yeah, there was a lot of enthusiasm and interest in what you had to say. I'm putting a link in the chat that has the link where you'll find this recording and the slides, probably in a week or so on the Health Literacy Solutions Center site. So again, thank you so much to Laura, Georgia, Lisa, and Dr. Satya for sharing this with us. It's excellent work that you're doing, and it's really nice for us to hear about it. And thank you to all the participants who spent this hour with us, and we hope to see you again for future webinars. Thanks again, everybody.
Thank you.
Bye-bye.